Hi, everyone, and welcome to Ask Your Embryologist. This evening, we are talking about mosaic embryos. What are they and why do they matter? My name is Sandy Christensen. I'm a clinical embryologist and fertility educator and advocate. I am based in the UK, and today we have two wonderful experts with us, and I will let you both introduce yourselves. So Cesar is joining us from Fertilab in Spain. Cesar, why don't you tell us a little bit about your background, please?
Well, I'm a genetic counselor for Fertilab. Is a clinic in Barcelona, that a reproductive center. So I'm performing the genetic consultations for patients that require some kind of information during their process in the center that requires some genetic testing, and that is my major thing to do in our center.
Perfect, thank you. And Rosta, you are joining from Repromeda in Czech Republic. Would you mind telling us about yourself as well?
That's right. Nice to meet you all. Thank you for having me here. It's an honor. Yes, I'm from Repromeda. I'm a molecular geneticist, and I work as a head of molecular genetics laboratory here. And I've been in the field for almost 11 years. And my specialty is preconception genetic testing and preimplantation genetic testing of embryos. So, yeah, mosaicism as well.
Brilliant. Thank you so much. No, we're very lucky to have you both here tonight. Thank you so much.
Thank
To
you.
everyone who is joining and listening in, please feel free to drop your questions in the chat box. We will try to get to them all this evening. Just to make you all aware as well, this session is being recorded, but your name will not be recorded. So any questions that you ask will not show in the recording later on. If anybody needs to dash before the end of the session, the recording will become available. So if you have signed up, that will be sent to you when it is published. So I thought first and foremost, we might talk just in general a little bit about how you get a mosaic embryo. So the actual PGT-A testing and when that might be performed and recommended. So Cesar, do you want to tell us a little bit about PGT-A just in general, what happens during the process? And then we kind of get around to the possible results from it too.
Well, PGT is a technique to try to diagnose the embryos to characterize the chromosomic composition of those embryos. So we try to offer this technique to couples that have some risk of having increased number of aneuploidies in their gametes. So they are producing embryos with aneuploidies at major risk. Indications, of course, maternal age is one of the most the highest one because of our lifestyle today. So make us take the decision of reproductive projects in advanced moments in our life. Recurrent miscarriages or having some structural aberrance in the karyotype of people who's carrying in the cardiac are different indications for indicate that PGT-A to the people. And in the last years, of course, the own decision to increase the pregnancy rates is a common one, not for a medical background, but for just to increase the chances to get pregnant in each transfer, in embryo transfer. So, are different indications for offering PGT-A, and those are the most common ones to offer to the patients.
Yeah, no, that's very helpful. Thank you. And yeah, in the biopsy technique in the laboratory, obviously we're trying to take enough cells to be able to amplify and to get a good result, but at the same time not too many to damage it. But Rosta, how about you? Would you want to tell us a little bit about what types of results you might get from that testing?
Of course. What types of results? Yeah. One of these are full aneuploidies. It's one of the most common. And the full aneuploidy means that you have one extra chromosome or you have one chromosome missing, basically, in every cell of the biopsy. Usually these embryos are not viable, but we have chromosomes like chromosome 21, for example, or chromosome 18, chromosome 13, which are well known for disorders like Down syndrome. And Down syndrome is extra chromosome 21, actually. So these are viable or can be viable. But the rest of these chromosomes are usually miscarriage and so on. And that's one type of the chromosomal aberrations we saw in PGT-A. The other type is segmental aneuploidies. It means that just a part of the chromosome is missing or is extra. And both of these findings, the aneuploids, full chromosomal aneuploidies, and the segmental aneuploidies, can be in mosaic. And it's basically the same thing, but the difference is that you have in the biopsy, you have cells with the normal set of chromosomes together with the cells with these aneuploidies. And the combination of these two is a mosaicism, basically. But the finding and the biology behind that and the genetics behind that is basically the same. It's a missing part of the full chromosome, or one chromosome, or the part of that extra.
Yeah, reflect on that. I think that basically covers a little bit that first question that we got here today was, is there a cutoff on what is mosaic versus segmental aneuploid? Is there any distinction between the two, or would they be considered the same?
Yeah, there is a cutoff. Yeah, of course. If it would be great to explain what the mosaicism is, actually. I started it a little bit in the previous question. It's the state where, or a situation where you have a organism, like for example, embryo is, or a human being, it doesn't matter. And we consist of a lot of cells, right? And the mosaicism is a state where you have two or more cell lines with a different genetic information in one organism. That's it. That's a mosaicism. And when we are talking about the chromosomal mosaicism in the IVF embryos, it means that it consists of different cell lines, euploid cell lines and aneuploid cell lines. And when we perform the biopsy, you take, for example, 5 or 10 cells from the embryo, and you will perform the PGT-A on these, for example, 10 cells. And then you can have just few cells aneuploid, for example, 2 of them or 3 of them. And we will see that on the PGT-A result, that is a 30% mosaicism, right? And that's the cutoff. And that's very different in every laboratory, actually. Because, for example, our laboratory, the cutoff for calling the mosaicism is 30% for the low mosaics and 80% for full aneuploidies. Yeah, but when you look at, for example, recommendations of professional societies like European Society of Human Reproductions and so on, they recommend to call mosaics from 20%. So it very differs between laboratories.
Yeah, that's a very good point. Cesar, what are the cutoffs where you're based in Spain?
It's depending on the provider of the genetic results, of course,
Right.
because there is not a legislation or something like that. There are only recommendations about how to proceed with the genetic analysis in PGT-A. So, of course, the internal controls of each provider are different, and the internal biostatistical systems to confirm the results are different. So all the even most of them has similar procedures are not the same one to each other. So that means that we have different systems for the analysis depending on the provider of the genetic analysis. And that's one of the things that makes difficult to unify all the information about mosaicism and to get into one single way to manage them. So it's difficult to unify all the information about the mosaicism. As Gustav said, some laboratories put the cutoff in 20% in the lower side of the to the side that is mosaicism and not a complete aneuploidy, and in the highest or normal or euploid embryos, and in the high side between 70 or 80%. It's depending on the provider. So it's difficult to. But anyway, when you decide to work with a genetic provider, you have to manage with the rules he provides you. So anyway, the results are consistent with the provider that gives you the results, and you have to go with those results and manage with patients with those results. And this is the tricky thing to do.
Absolutely. And so something that we spoke about a little bit backstage before joining was also around that, specifically around kind of how to approach someone about results, and you said something really brilliant. It's kind of about managing expectations, and that you need to, you know, help the patients understand what to expect before they actually do this. And how well do you think that happens in clinics?
Not very well.
Realistically.
No, not very well. Unless in Spain, it's not quite common to performing to give the complete and right information to the patients, because it's important to make talks with patients prior to performing the testing. It's very important that they understand what we can get with results in a PGT-A, because they are expecting only to having the results in euploid or aneuploid, normal or abnormal. That's why they are expecting. But with the actual techniques that we are managing, we know that mosaicism is one thing that can happen. Between 5 and 15% of the results in PGT-A are giving us a result of mosaic. And if you don't have given a complete information to the patients prior to performing the testing, the expectations that they have maybe are not accomplished when you are bringing them the results, and they don't understand what does it mean that the mosaic, what happened with this result. It's good, it's bad, is can I transfer that, can I not? This embryo can bring me a pregnancy, a healthy pregnancy, because it's not only the pregnancy, it's that it would be a healthy pregnancy if I decide to transfer this kind of embryos, not. So for me, it's very important to inform very well to the patients prior to performing the testing, to manage with the expectations that they have with the results.
No, absolutely right. Yeah, I think in some cases it is sold as a treatment add-on, to your point earlier, for those who have experienced recurrent pregnancy losses, or recurrent implantation failures, or those who just want to possibly shorten their time to pregnancy, and you know then that you're going to be transferring something that has been tested chromosomally, could increase your chances of pregnancy, and then the other information kind of gets lost. Like, but the results could also mean XYZ. So yeah, sometimes it's not as well explained in the clinics as it could be. So we've got another question here, which I quite like here. How much training does an embryologist do before being able to perform PGT-A? Rosta, do you want to take that one? Do you know?
Actually, I don't know how it works in Spain or other countries, but embryologists are not doing the PGT-A usually. Embryologists doing the IVF part and doing the biopsy of the embryos, and then they will send the biopsy to the molecular genetics lab, where we are performing the PGT-A. So if the question would be how much training does an molecular biologist do before doing the PGT-A, I think it's, the basics of the PGT-As. It's very easy. It's very easy to understand. It's very easy to perform it good. I think to do it very well, it's about the experience, about the years of doing that, about the society's recommendations, about meeting the people from the field, talking about the problem, read the papers and so on, and you're getting better and better and better. But to say how much time it takes to do it really well, it depends person to person. It's hard to say.
I think
I've been in the field for 11 years and I'm still learning that.
And
That's
there
a
are
great
different
point.
steps in this procedure. So there are a lot of critical moments during this procedure. The biopsy is one critical moment. Putting the sample into the analysis tube is a critical moment. The PCR previous or the amplification in the molecular lab, it's a critical moment. So there are a lot of critical moments during the procedure, and patients only thinking, please don't hurt my embryo. They are only focusing, please, if I biopsy my embryo, it will be damaged, but they don't understand that it's much more complex than not only the biopsy. All the further steps are as critical as the biopsy. Of course, the most critical for the embryo surveillance is the biopsy, of course, because embryo, once you take off the sample, still in the culture media or it's frozen and stuff there. But for to having a good results, next steps are as crucial as the biopsy as well.
Yeah, and also the freezing protocol is very crucial.
Yeah, that's right.
Absolutely. I think you've both touched on really good points here, and it's something that maybe not every patient understands.
But anyway,
And
I just want to remind that in good hands, this procedure is pretty safe for the embryo and pretty reliable for the results that we are providing to the patients. So in good hands, it's not a big deal to performing this testing to the embryos. So that's one thing that they must understand. In good hands, it's not a big deal for the embryo. If it's a good quality embryo, of course, if we are biopsying embryos that in blastocyst moment that we are performing the biopsy, they are of very bad quality. The embryo was a very bad embryo at the moment of the biopsy. If the embryo do not continue developing, probably was not because of the biopsy. It was because it was a bad embryo at this moment. So in good hands and good embryos, it's not a big deal to perform a PGT-A to the embryos. And that's one thing that they must take into account.
Yeah,
definitely, absolutely right. And I think for those who just see PGT-A as this whole process, I think it's been really good to hear about all of these critical steps that are involved. So a biopsy is when we actually remove the cells from the blastocyst on day 5, day 6, sometimes day 7 in the laboratory, and that's performed by an embryologist often. Mostly. Then typically the embryo would be frozen and stored in the clinic. The cells, and these are tiny, they get placed into also very small tubes. And that is one of the critical moments that we were talking about here, because it can be very hard to visualize these. Those little tubes are then put in a freezer and then sent off to the genetics laboratory to be tested. And one of the first critical steps you talked about there is the amplification, so the PCR. So there's a lot of little steps that are happening behind the scenes that we just see as, a blanket PGT-A. Each of those steps have risks involved. So there are risks when putting the cells into a tube. If you can't visualize them, there's a risk that they might not have been there in the first place. The result could come back with the report saying no result. So there wasn't enough DNA there for amplification. The cells maybe didn't make it. Sometimes when you have poor quality embryos, if you don't get good enough cells, that could also lead to a no result, for example, not enough healthy DNA to amplify. And then the times when we do get results, if there is, whether it's euploid, aneuploid, or mosaic, there's no error in the laboratory that could cause that result, right? That is purely from the chromosomes in the embryo itself. So I hope that answers your question. And then someone is asking here, how accurate is PGT-A on frozen embryos? Rosta, do you want to start with that one, please?
That's a good question, actually. Yeah, I can imagine that for some people who don't really understand how it works, it's really hard to imagine how it can be possible to freeze embryos and so a whole procedure around that. Actually, we have a lot of experience with the freezing protocols and so on. And at the moment, the freezing protocols are so good that it doesn't affect the quality of the embryo at all. Yeah, and But the biopsy for the PGT-A is performed before the freezing, right? So it doesn't affect the quality of the biopsy.
Well, there are some clinics that will thaw frozen embryos, perform a biopsy, and refreeze the embryos.
Yeah, that's yeah. Sometimes
I'm wondering if
yes,
that's the question
yeah,
here. Yeah.
that's true. That's true. Sometimes this happens. For example, when you have some specific findings, like for example, segmental aneuploidies, because we have segmental aneuploidies, and we recommend in these cases that you can perform the rebiopsy of these embryos. And in this case, you need to, because they are already frozen, right? They are in somewhere in the fridge, and so you need to take them out and perform another biopsy. But in these cases, it always depends on the quality of the embryo. Yeah, if the embryo is in a good shape, it will make it, right? If it's not, it can be problematic, and sometimes it can kill the embryo.
And so some couples performs several cycles prior to performing the PGT-A because they don't have enough embryos to proceed with the technique. So they use to accumulate embryos for having a nice pool, enough pool of embryos performed to going with the genetic testing, and it's not so uncommon to perform the biopsy in a previous frozen embryo. But as Rosta tell, the vitrification methods, the freezing methods of frozen embryos in now that we are using nowadays has a surveillance ratios very high. So they are not a big deal to performing the frozen and unfrozen embryos. Is most the most thing that we can be worried about is about the quality of the embryo, not the technique that we are performing with these embryos. And we go back to the same. The quality of the embryo is one of the most important things to having a good quality results in the PGT-A technique. I'm not talking about that the embryo will be euploid or aneuploid. I'm just talking to having good results of the genetic testing of this embryo.
Yeah, good quality data.
Yeah.
Exactly right. Thank you so much. So we do have another question here. And this is probably something that's different everywhere, but someone is asking, why does my clinic say it will take around 4 weeks to get PGT-A results, but some clinics advertise that they can get the results in 2 days? Is there a difference in the analysis method? Who wants to go first? Everyone's giggling. Rosta, why don't you go first?
Yeah, it's a very good question, actually. Yeah, it's true. It's true. For example, in our case, we have 4 weeks also here in our laboratory, but it is possible to do that in 2 days. It is possible. And why is it more expensive? Because when you perform the PGT-A in your laboratory, you're doing it in batches. It means that you're not doing one single embryo. You're doing several embryos. And at the very end of the PGT-A protocol in the laboratory, you're doing something which is called next generation sequencing. And it's quite expensive thing to sequence the DNA of embryos. And these machines, they have some capacity, right? But you need to use the all capacity always. And if you fill the capacity of the machine to the maximum, it will take some time to collect all the embryos. You need, for example, 200 embryos to fill the machine. But if you want to do that more quickly, for example, just in 2 days, you can do it also, the same thing. The whole procedure is the same, but you will not have 200 embryos. You will have just 10 of them, right? So it will be much more expensive. Yeah. That's it.
It's a cost-effective situation.
Same method, just you either get the exclusivity of the machine to yourself, your embryos, or they are analyzed with multiple patients. Thank you both so much. Okay, we've got another question here. Right, considering that the PGT-A process is outsourced, so the testing itself, who discusses the results with you? So as a patient, do you get results explained by the operators performing the test or the embryologist doctor at your clinic? And there's a thank you for your informative webinars. You're so welcome. And thank you for your question. Yeah, I guess typically where I used to work, embryologists or doctors in the clinic would provide the results from the reports that we got from the genetics laboratories. But I don't know if you have any different experiences, Cesar, in Spain. What's it like?
Of course, we are giving the results to the patients, the embryologist team or the genetic counselors team to the patients. But I know that some genetic providers has their own units of genetic counseling in the molecular lab that can offer this kind of management with the patients. So, but the most often thing, unless in Barcelona in Fertilab, is to proceed with the information to the patients about the results. Performed by the embryologist or the genetic counselors team. This is the most common thing.
Yeah, Rosta, is that the same where you are?
No, we have a little bit different situation here in Czech Republic. We always provide the results to the medical doctor, not to patients. And the medical doctor will consult these results to the patient always. Yeah, and if there's some specific finding, like for example, mosaicism is, we always recommend to have a consultation with a clinical geneticist.
Yeah, and I think it's if you get a report where you have euploid, aneuploid, the easier cases, that's a bit simple to provide that information to patients. The more complex cases, often you'd have a genetics counselor to have those discussions alongside because of any possible implications of transfers with mosaic embryos. Exactly.
Yeah, that's true. That's true because, for example, if you have just euploid and aneuploid embryos in our IVF clinic, gynecologist can do that, can do talk with the patients and so on. But if you have these specific findings, there's a need of clinical geneticists.
Any genetic report has the aware that genetic consultation must be performed with the patients to offer the results of any genetic results or any genetic testing. So that must be offered. Of course, the management of euploid or aneuploid results is easier than other complex results when we talk of mosaic embryos, of course, or when we talk some complex rearrangements in or molecular diseases that can be tested in PGT-Ms or so. Those kind of results are more complex, and of course, always we have the disclaimer that genetic consultation must be performed with the patients to offer the explanations about the results in any genetic test.
Thank you. Is the rate of mosaicism correlated to maternal or paternal age, like aneuploidy can be? The next question.
Well, until not so long ago, we were saying that no, but more recently, now we know that maybe with the high prevalence mosaicism, maybe the maternal age can be related with this mosaicism. So when we are talking with low ratio, with low representation of mosaicism, maybe not, but with high representation of mosaicism, more than 50% of the cells analyzed are anormal in the mosaicism. In those cases, probably the maternal age is one of the things that can involve in this increased number of mosaicism. I don't know what Rosta can say about this, but that's the thing that we are thinking at this moment. Maybe in the future is changing this information too, because we have changed since 3-4 years ago. But nowadays, this is the most common thing that we think happens with maternal age in the high representation mosaicism.
Yeah. From our point of view, I think personally that the mosaicism is not affected by the age, not definitely as the full aneuploidies. But you can, when you look at the data, you can see that older women have a little bit higher percentage of mosaicism. But I think about that because these women have much higher rate of full aneuploidies. And some of these full aneuploidies, for example, especially trisomies, they can self-repair during the mitosis. So at the beginning, you have the full aneuploidy. And during the mitosis and the early stage of the embryo development, some of the cells will lose the extra chromosome and they will self-repair. We call it a trisomy rescue mechanism. And you will gain mosaic embryo from that. And I think that these little, it's just a few percent of mosaics in the older women. But I think that because they have much more full aneuploidies, so they have more frequently list trisomy rescue, probably. I think that could be the reason. But from the biology point of view, how the meiosis and eggs development works, I think it doesn't affect the age. Doesn't affect mosaicism.
Now we are getting into the mechanism of mosaicism, and here what we can say is that mosaicism is a biological thing that we see in the nature. So mosaicism exists in the nature as a biological thing that we can find in individuals. But in the other side, we know that we are seeing more mosaicism that we expect to have in the nature, in the biological nature of the human being. So what is the origin of this mosaicism and the mechanism? As Rosta said, the most common mechanism is after the fecundation, is a mitosis process in the most of the cases. So as Rosta said, in these cases that are the most common, the age of the individual is not a big deal to explain these mechanisms of formation of mosaicism. But in the other side, we are looking at much more mosaicism that what we expect to find in the real nature, and that probably is due to the things that we are performing to get the results in the PGT-A, the biopsy, the tubing, the amplification, the biostatistical analysis that we perform with the results. So in all those steps, we can put in the hand of the man of the human being and having much more mosaicism than what is real. Or maybe it's just because we are looking at the trophectoderma, not the universal mass and the future baby. Whatever it is, what we know is that we are seeing much more mosaicism in our PGT embryos than what we expect to find in the nature, and that is related with the mechanism of mosaicism and with the procedure performing the PGT-A, probably.
Excellent discussion. So that kind of brings me to how accurate do you think the methods we're using today are at detecting mosaicism?
For euploidy and aneuploidy, quite good. Are you agree?
Exactly.
But we can go into the mosaicism, and what we know is that any, and when I say any embryo, mosaic embryo, is able to bring a healthy pregnancy with higher risk, of course, and we have to classify the risk and the expectations to bring a pregnancy. But what we know or what we suspect is nowadays any kind of mosaic embryo, even the ones that we presume they have in the higher risk or the less possibilities to bring a pregnancy, even those are able to bring a healthy pregnancy to the couples with their and couples must understand that they have to manage with the risk related with these embryos are not as safe as an euploid embryo. So if any mosaic embryo is able to bring a pregnancy, a healthy pregnancy with the risk related with mosaic embryos, so that goes to the other side that it's pretty reliable, the results that we are having, or maybe there are correction mechanisms that happens after the diagnosis. There are several explanations for this, but maybe some of them are more common and some of them are less common. But of course, the first thing that the couples has to know is that Mosaic Embryos has potential for their reproductive projects, has a potential, but of course they are higher, they has higher risk than an aneuploid embryo and less probabilities to bring a pregnancy. So this is a balance that they have to manage with a good information, of course, with a good genetic counseling prior to decide what to do with those kind of embryos. But it's important that they know that any mosaic embryo is able to bring a healthy pregnancy, of course, with the related risks that they can have instead.
That's excellent. Thank you. Yeah, the results, it's a very, it's a, I think, a reliable test that we have available to us now.
Yes.
And we are very grateful for the advancements in the technology, like we were talking about earlier. Cesar, you said you've been working for many years in the field and have been around since one of the first techniques where this biopsy was performed on day 3 embryos, and the results were not as accurate. So thank you so much for that. Rosa, I've got another question here, which is, are there any benefits or consequences to consider when choosing a clinic for PGT-A? So what things would a patient look out for when trying to select a clinic and wanting PGT-A testing?
Yeah, I think I mentioned it before. It's definitely the experience, of doing the PGT-A. It's a crucial thing. Yeah, if it's a well-established, very old IVF clinic or the laboratory which has thousands and thousands of embryos per year, and I think they would be better doing the PGT-A. Yeah, but of course you can have a very new genetic laboratory with the new people. They can be very good. It's very hard to answer this question. Yeah, but if I am the patient and I'm choosing for the laboratory doing my PGT-A, I would definitely choose the bigger ones with the more experience doing that. And that's the one thing, the experience. The other thing is also the procedures they use, the tests they use, and also the development they do. Because there is not the only one universal test for PGT-A. You have several types of these tests. And for example, our laboratory is developing our own tests for PGT-A. And we're adding some extra things to the PGT-A to make it more accurate and so on. So I think it's great to go to the website, read about their techniques, read about the advantages, and so on. For example, when we were talking and you asked about the accuracy of the technique, it's a crucial thing. Actually, it's a cornerstone of a good PGT-A, the accuracy of the whole procedure, and especially the software you use for PGT-A. And if you have, for example, bad quality embryo, it will lead to the bad quality data, and it's biased a lot, and it can lead to, for example, to false positive calls. And you think that you have mosaic embryo, but actually it's a euploid embryo. On the other side, you can have a false negative calls. You can report high percentage mosaics, but in fact, it's a full aneuploidy. And that's a huge risk. But we have techniques how to recognize if it's a true mosaicism or it's not. For example, using something which is called single nucleotide polymorphisms in a PGT-A and so on. So these additions to the PGT-A are also crucial for accuracy of the thing. But all these informations you can read on the websites of the laboratories, definitely.
Yeah,
And in
do
the
you have
era,
anything additional?
and in the era of information that we are in, for patients, in the most of the cases, it's difficult to reach to get this information. Patients can get the information of the IVF centers, and there are forums of patients that can talk about the results that they get in going to this center or this other one. But for the technical information about the genetic testings, people has a very few information. Moreover, in the most of the cases, people who goes to an IVF center, they don't know whom this IVF center is working for the genetic analysis, because are two separate works for them, for patients. Patients decide which IVF center goes to, And the IVF center decides internally which genetic provider has to perform the genetic testing. So reach the information for the patients about which IVF center works with the best genetic molecular laboratory. It's impossible at this moment. So in my opinion, the first step that they must do is to try to go to an IVF center with a good reputation. And the reputation is not about the website of this center. It's about the forums, about people who are going there, about patients who talk about them, about mouth to mouth. So this information at this moment is getting not in the website of the center. It's getting about the patients forums or so. And if you're going to a good reputation IVF center, probably they are working well. And why? Because they are doing the things well in the IVF laboratory, but because we are sharing and working with the best providers that they can get. So all goes together. But for patients, I understand that it's pretty difficult to get the information about the molecular center that is performing the genetic testing to decide, well, I go to this IVF center because they work with this genetic provider and they are the best. So it's quite difficult to go with this chain.
Yeah.
So.
Yeah, definitely. And usually these well-known IVF clinics, and if they're good and they have good reputation, as you said, they very probably cooperate with a very good PGT-A laboratory.
Yeah, that's right. That's right.
Thank you both so much. We've got another question here. So I will try to read this very carefully, and thank you for sharing all of this detail. So this is a 36-year-old who had 5 blastocysts that were PGT-A tested. 3 were aneuploid and 2 were low-grade mosaic. So the first resulted in a negative pregnancy test, and unfortunately the second miscarried. So testing of the baby proved genetically normal, and the doctor says that they are cautious about using mosaic embryos in the future. Would you agree with that? It's a tough one. I think in the previous webinar that we did, we talked about all of the things that are involved in implantation and how it's not just due to the embryo itself. You know, there are internal hormone levels, there's the uterine environment, lining thickness, things like that. Maternal age, unfortunately, also always a factor that's involved. But do you have any thoughts in regards to mosaic embryo transferred, testing of the baby remains proved to be genetically normal? CSO, you've got thoughts.
What we know is to get a pregnancy, the genetic constitution, the chromosomal constitution of the embryo is crucial, but it's not the only thing, of course, because if it was the only thing, each euploid embryo that we transfer will bring a pregnancy to the couples that are receiving these embryos. And we know that that doesn't happen. It's around the 60 to 80% of the euploid embryos that we transfer, depending on the IVF center, of course, on all what we have been talking about previously. We are getting results of pregnancy transferring euploid embryos. So what we know is that it's crucial to having a normal chromosomal constitution inside the embryo, but it's not the only thing. And when we are talking about mosaic embryos that to be caution with those transfers, of course, mosaic embryos are not euploid embryos. But what we know at this moment, as I told you before, is that those embryos must to be offered to the couples in the reproductive procedures, being very well informed previously to the decision of transfer or not those embryos. But as we know, they are able to bring healthy pregnancies to the couples that decide to transfer, so they must to be offered to them. And couples with the autonomy principle of deciding to transfer or not the embryos in a context of good information about the mosaic embryos, they finally will decide if they if they go on with a risk that they were informed or not. And what we know at this moment is that low ratio of mosaic embryo of mosaicism in the low ratio mosaicism embryos, the results of pregnancies and healthy babies are quite similar to euploid embryos. In the other side, we have the high representation mosaicism embryos are not the same. But with those embryos with low ratios of mosaicism, lower than 50%, the results in pregnancy rates and healthy baby at home are quite similar with euploid embryos. So all this information that we are knowing with time must to be shared with the patients, and not to be, we don't have to give them some theories about bad things that can happen if they transfer those embryos. We just have to inform about the real things that we know at this moment, and then with the principle of autonomy, they will decide what is the best for them. But let's give to the patients the option to decide with a good information previously.
Yeah. I think if I go back to may I answer also to this question, because
please, yes,
when I look at
absolutely.
these questions, there's a sentence: my doctor is cautious about using mosaic embryos in the future in this case. But in this case, as you mentioned, and very probably it wasn't because of the mosaicism, because these embryos were genetically normal. You can see that, clearly see that. So there is no reason to avoid transferring mosaic embryos in the future at all. And if you're going to have another cycle, and you will have, for example, I don't know, 2 euploid embryos, 1 euploid embryo, and other 3 mosaic embryos, you have definitely go for the euploid one as the first option. It won't come out. Try another mosaic embryo, because there's a huge chance to get a healthy pregnancy, have a baby from that.
That's perfect. Thank you. I hope that answered your question. We've got a few more to try to get through this evening. Someone is saying that in their experience, some clinics don't give any percentages to the mosaicism, but classify them as LLM or HLM. So I'm guessing low-level mosaicism or high-level mosaicism. Why is this the case? Do you have any thoughts around that? And we did touch on this a little bit earlier, that some, different genetics laboratories might have different classifications, that 20% and lower could be considered low level, whereas others might have that cutoff as 30. So that could be one of the explanations, but I don't know if you have any experience with that, Cesar Rosta.
It's very hard to answer this question, because you have a lot of laboratories, and they have their own decision tree, how they do and how they perform the PGT-A, how they evaluate the embryos, how they call these findings, and so on. So we do that somehow. We call the mosaicism from 30% to 80%. We clearly state the percentage of the mosaicism on our results. But it's our laboratory, and we have a lot of different attitudes, a lot of different points of view, and so on. But I can't give you an answer what LLM or HLM means in this case, because it can be higher, more than 50%, lower than 50%, for example, or it can be 60%. But I think it should be clearly stated somewhere in the protocol. It's the crucial thing, how we do that, what it means. It should be somewhere there. If it's not there, it's wrong.
And the further genetic counseling is crucial to have the whole information about the result of this biopsy, to manage the information that you are providing to the patients. And some clinicians decide to do not offer those kind of embryos because they are afraid of not understanding what is happening with these embryos and what are the risks. So they don't want to manage this risk, and they finally decide, I don't inform them, or I don't want to be informed about them. Just tell me that they are not euploid, and that's good for me. So in my opinion, that is a bad procedure, a bad medical procedure, because if we have the information and we have the certainty that those embryos can be useful for the reproductive projects of the couples that we are managing, having all the informations and bringing this information as complete as we can to the patients and let them to decide what to do with them or not. It's a very important thing during the IVF process.
Yeah, and you mentioned autonomy before, I think, as well, and it's about getting all of that all of the information so you can make an informed decision going forward. So it's very possible that the clinic does have the information, but maybe they are not presenting it to you in that way, either to make things easier or trying to not overcomplicate things in a roundabout way. It is possible that they do have it, and I've chosen not to present it to.
And some clinics decide to don't get this information, don't receive this information. Just tell me the euploid ones, and the other ones, bring me them as not transferable. So we can find both situations. The one that they don't receive the complete information, or maybe the clinician don't want to receive the complete information. That is possible too.
That's true. That's true. Thank you both so much. We've got another couple of questions here, and we'll start off with thank you for the insightful presentations. As science progresses, we're witnessing a deeper understanding of mosaic embryos, not only at a chromosomal level, but also through transcriptomic and AI-based analyses. Oh, yeah, we listened to a lot of talks on that at ESHRE. So one question here, the recent transcriptome analysis suggests that embryo mosaicism affects metabolic and mitochondrial pathways differently, depending on the level of mosaicism. So how should this molecular profile inform embryo selection and counseling for implantation? That is a complex question. Rosta, would you like to go first?
We have a lot of information to try to classify embryos. We are the genetical dynamics, the morphology, the PGT-A, the mitochondrial function, or the amount of mitochondrial to try to understand if the activity of this embryo is good or not. The transcriptome information, not only from the embryo, but even for the from the mother that will receive this embryo. So parameters to analyze, we have a lot, but to try to manage all this information at this moment is complex, but it's very complex. We know that the dynamics of the embryo and the morphology embryos are good quality parameter to classify the quality of this embryo. The genomic constitution, as we know, for the experience that we have with the years, that brings the PGT-A, is a good parameter of classification of this potential that this embryo, as being chromosomally normal, can bring a pregnancy. And transcriptoma and the mitochondria pathway, amount of mitochondrial and so on, are more parameters that we can manage, but are not as good reliable for bringing the information of what to transfer or not, that the other things that I mentioned previously. So this information is important and can be added to the three decisions, maybe, but are not. We have not the demonstration or the knowledge at this point to decide that those are critical points to take into account in the decision tree to transfer or not the embryo, more than the morphological and genetical parameters, and of course the PGT-A results. I don't know what Rosta.
Yeah, I totally agree with you. But for example, this very particular thing, transcriptome analysis in embryos, it's a huge thing, but it's at the very beginning now. Yeah. And I think it's in development. I saw some very interesting presentations about that. I saw some very interesting data. It's very promising, but we are not there yet, right? PGT-A, as it is now from the normal biopsy, is definitely better at the moment. But in the future, it maybe somehow will be better. I don't know. Yeah, but we had, for example, several years ago, something which is called non-invasive PGT-A was developed from the culture media, right? And we are here 5 years or 7 years later, and we are not doing that because we know that it was just a dead end. Yeah. And the PGT-A from the biopsy was definitely better. We will see what the transcriptome will give us in the future.
I actually started a metabolomics project when I was working in Sweden back in 2009 or 2010, using spent culture media. And yeah, it's not come as far as we would have liked. That wasn't necessarily in regards to euploidy rates, but still that was at the kind of the very beginning, I think, and trying to assess blastocyst prediction and things like that. And I think there are other models that might be better at this than the spent media. But the second question here is around the AI tools. So with tools like IDAScore, improving embryo assessment, how do you see AI integrating with PGT-A in reducing subjectivity and better predicting implantation potential of mosaic embryos? Very great questions tonight. Thank you so much.
That's a very good question, because it's something we are dealing with every day. AI, right? We all use ChatGPT every day at work, especially to make some fun pictures. But also we are thinking about implementing AI into the PGT-A as well, also in our laboratory, because the thing is that when you are performing PGT-A, you are evaluating these results. You have always some human there, and you have 5 different person doing the PGT-A, but you can have 5 different results. That's it. Yeah, and you can make rules how to do that, but you have these noisy data, you have bad quality embryos, and sometimes it's a mess, and it's very subjective, evaluating these embryos. But I think I see it as a quite promising thing to implementing AI in a PGT in the future, because it will be better than any human ever, because it can have the information about all PGT-A's profiles ever existed, right? And it can learn from a lot of data. So I'm quite a fan of that.
Yeah. What about you, Sifo? How do you feel about AI coming in the mix?
AI is being using in the IVF laboratories. AI is being using for compare the dynamics of development of the embryos to give a score of quality, or to manage the what we expect, the expectations that we have with those embryos to bring a pregnancy. But all of these are tools that put it together. Use all those kind of tools, all tools together. We can increase the results that we are having in an IVF center. But just using at this moment, using a single tool like AE for everything, we are not at this point. It's not a thing that we can think about, because we are not at this point. But maybe using altogether the tools that we are having at this moment at the laboratory probably will increase the chances of bringing a pregnancy for the couples that they are looking at. So use all of them together is the best procedure that we can do at this moment in the IVF centers.
Yeah, for example, at the moment we have the AI softwares in embryology. It's been here for years, and it's developing a lot, and it works quite well. So maybe in the future, these AI embryology tools can be combined with some AI tools for PGT-A, and it will have all the information it needs to get a better results.
And I think to your point right now, using them all together is really where we'll learn a lot, will help influence the development of these tools better so that the tools learn. Because the follow-up question is then, do you think that AI could help avoid the biopsy in general in the future? So a non-invasive technique, for example. Do you think that is on the cards? There were a few presentations on that at ESHRE. The reliability rate is not very high at the minute. So we're definitely not there yet long term. But what do you think?
Yeah, maybe in the future. Yeah, we're not there yet, but you can see what AI did in the last 2 years, right?
Yeah.
And I think it will be huge in the next 5-10 years. So we will see, and I think it's possible.
We don't know.
Yeah.
Excellent, thank you. We've got another question here. We've said tonight that quality is important, so the quality of the embryo for accuracy of PGT-A, and what grading would be considered excellent, good, or not good in terms of doing PGT-A. Do you have thoughts on that? I know you you received the samples to do the analysis. Do you have any thoughts on embryo quality based on what you see in the laboratories?
Embryologists, they are doing a follow-up of each embryo that they have in the laboratory, and they are watching all the development of this embryo day by day, hour by hour. In the culture systems that we are having at this moment, we can follow up the embryo since the moment that we put inside the culture system and see what happens minute to minute, second to second to those embryos, and all those and this follow-up of how the embryo divides, how if there are fragmentation or not, the speed, the dynamics of this development of the embryo are the parameters that the embryologist uses to give a qualification of this embryo in terms of quality. What is good, what is bad, what is medium quality? It's depending on the fragmentation, the kinetic dynamic of divisions, and all the parameters that the embryologist uses to bring this qualification. So what is the qualification that is good or bad in an embryo? What the embryologist decide at the moment of the performing the biopsy using all those parameters.
Yes, exactly. I think for our work, it's crucial the information about the quality of the embryos from the embryologist, as you said. For example, in our IVF clinic, they provide information about the bed cell divisions, because there can be a risk of, for example, the triploidy or haploidy in the embryo. So you can use, for example, absolutely different technique for the PGT in these cases. Or a very crucial information is about the quality of the embryo at the very end of right before the biopsy, because sometimes when the embryo is in a bad shape, it's lysing, and these cells in the biopsy are lysing, and it's very bad quality. That's a really important information for us doing the PGT-A, because we know that this profile, which is very noisy, it's not the biology, it's the quality of the biopsy. Yeah, and these embryos can be viable if they will be in a good shape, if they will implant. But usually these embryos have lower implantation rates. Yeah. So yeah, the information from the embryology is crucial.
Yeah, and typically we do see a lot in the laboratory when performing the biopsy itself, how the embryo is responding to whether or not we're using a laser or doing a flick to remove the cells. We can tell, what happens during that time, and to your point before, we can tell a lot during the culture with time-lapse incubation. If there have been any abnormal developments along the way, we would always make notes of these things that we would send along with the samples themselves to the genetics laboratory, so that they can, so we can try to match those things together. Did this correlate with this, and things like that. So excellent questions. Thank you both so much. So that was all of our questions here this evening. We have gone over a little bit. I do appreciate your time. Thank you both, Cesar and Rosta. It has been a pleasure speaking with you. Thank you to everyone who joined and who asked wonderful questions. I hope you have come away with a ton of knowledge going forward and a bit of support for any future cycles. You can join us again. We've got a break coming up in August, but our next couple of sessions will be starting up in September, and the Ask Your Embryologist will be back on September 9th. Have a lovely evening, lovely summer holidays coming up, and thank you so much again. It has been really lovely.
Thank you too. Thank you.
All right, take care. Yeah,
Bye-bye.
definitely. Bye. Thank
Bye-bye.
you.